So my topic was basically yellow spots, but I took little liberty and I extended to include yellow dots as well, because you never know when dots become spots and spots can get converted into dots. So these yellow spots or dots, they are common occurrence in day-to-day practice. Almost every other elderly patient would have some of these yellow spots and dots. And of course, they are much more significant in existence if they occur in younger population. Some of these can be normal, for example, drusen. They can be indicative of a benign pathology inside the eye, something like hard exudates, or they could be indicative of more sinister underlying pathology, something like metastasis or choroiditis. But remember, some of these, for example, even drusen, they can be a harbinger of a more sinister pathology. And similarly, hard exudates can be present in a condition as benign as hypertensive or diabetic retinopathy, or they can be associated with diseases which are very extensive and difficult to treat, something like hard exudates and retinal capillary hemangiomas. Whenever you see some of them, the first step is always a dilated thorough fundus examination. Never be in a hurry to see the fundus through a small pupil that I have seen everything and nothing else is required. It's always a good idea to have a good dilated fundus examination. And in most of the cases, appropriate history and relevant examination findings will help us establish diagnosis. And whenever in doubt, it is not a bad idea to investigate the patient further or take an opinion from an expert friend. Now, first, I'll be talking about something which we see day in and day out. It is called drusen. Now, drusen are multiple yellow deposits. Usually, they occur in the macular area. They come in various sizes and shapes, and they have varied distribution throughout the fundus. Now, some of the common presentations include the first figure over here, where you have multiple yellow dots which are scattered throughout the macula, and they may be associated with well-defined areas of uh, geographic atrophy from where you can see the underlying choroidal vessel. They may or may not be associated with a grayish membrane, as Mohit already discussed, which is nothing but a choroidal neovascular membrane. Now, they tend to have various distributions. They can have it can be localized but clustered in the temporal macula. They can have a more generalized distribution at the posterior pole. And then we have various kind of drusen, where we have soft drusen, which are nothing but large drusen. The drusen can coalesce to form drusenoid PEDs, which when again appear as yellow spots. And these can be associated with uh, their brother, something known as subretinal drusenoid deposits, which are nothing but the drusen which are above the retinal pigment epithelium as compared to the conventional drusen, which are below the retinal pigment epithelium. Now, sometimes they can be indicative of more uh, general disorder, which is present since birth, something like hereditary drusenosis, where they are present in thousands and thousands and can be associated with advanced atrophy at the posterior pole. There are times when you don't get these drusen only in the macula, they can be present in the periphery. So how do we distinguish them? They are deep, they are in the subretinal space, they tend to be well defined, and typically they are seen in the elderly population, but that is not the rule. They can be seen in the younger population as well. Typically they are distributed in and around the macula, and we do not see associated retinal vascular sign, which is a very useful sign to distinguish them from hard exudates. They can be associated with geographic atrophy or choroidal neovascular membrane. And typically, once we do OCT, it is very easy to see them because they are in the sub RP, or some of them can be above the RP as well. When the drusens they coalesce, they form drusenoid PEDs. And as I mentioned, drusen are typically harbinger or indicative of age-related macular degeneration. And all we need to do is counsel these patients. Some of them require AREDS formulation, and we need to keep these patients under strict follow-up. And we must explain them the risk of choroidal neovascularization. The next lesion I'm going to talk about is hard exudates. As opposed to drusen, they are intraretinal. Typically, they are well defined. They tend to be a little more yellowish, and they have associated retinal and retinal vascular changes in form of retinal hemorrhages, which can be cotton wool spots, sometimes microaneurysms, and even retinal edema. Now, as opposed to the distribution of drusen, hard exudates tend to be distributed around the retinal lesions, which could be a retinal vessel or a simple thing like a retinal artery macroaneurysm. Now, given you a host of scenarios, common scenarios where hard exudates can be present, these associated signs which are there, for example, a lot of uh, flame shaped hemorrhages, the hard exudates distributed in a star-like pattern, and optic disc edema indicate here that we are dealing with the case of hypertensive retinopathy. We are all familiar of diabetic retinopathy, where we see multiple microaneurysms and dot and blot hemorrhages. They can be seen in condition like neuroretinitis, where they are again distributed in a star-like pattern. They can be present in neovascular AMD and commonly PCV, a condition again seen in elderly, something known as retinal artery macroaneurysm. We can again see a lot of them. And a rarer pathology where they can be seen is something like Coats disease or retinal capillary hemangioblastoma. Now, one thing of caution here is that sometimes these hard exudates, especially in vascular conditions, they can coalesce and migrate to the subretinal space and form a yellow spot, something known as subretinal hard exudate plaque. Now, as opposed to drusen, they tend to be intraretinal, and they can or may not, they may or may not be associated with intraretinal edema. Now, some of the rarer lesions which can present as yellow spots is something known as best vitelliform. When you see such a material in the both eyes which is hyperautofluorescent, that can indicate best vitelliform dystrophy. Usually these patients are of younger age group. These lesions tend to be bilateral, and autofluorescence is the key to diagnosis. Something we see in middle age very commonly, CSC, but a rarer variant is where you can get something known as subretinal fibrin. Now, this can appear as a yellow spot. The key is, again, you do FA and you will get a well-defined ink blot leak, which indicates that we are dealing with a patient of central serous chorioretinopathy. OCT, again, will show you something known as eclipse sign, which can tell us the diagnosis. Choroiditis again is very commonly in the, seen in the eye. Again, and FA and OCT will give you a clue. Just 2-3 slides more. I'll take a minute to finish. So again, what you need to see here is signs of inflammation, which can be there in the posterior segment or anterior segment. And when you do FA in these patients, signs of inflammation in the terms of disc leakage is very important to diagnose. Some sinister pathology like choroidal metastasis can again present with yellow spots or yellow creamy lesions, which tend to be bilateral and multiple. Now, again, history in terms of elderly patients, OCT in terms of lumpy bumpy appearance of the retinal RP. And if you see excessive amount of subretinal fluid, that can indicate choroidal metastasis. Some other lesions, rare lesions, can present as yellow spots, for example, CMV retinitis, choroidal hemangiomas, which are decalcified. Last but not the least, this is a very interesting case, something which looks like a best vitelliform dystrophy, but when we did OCT, it showed that the lesion is in the subilum space. So this is nothing but altered subilum hemorrhage, which is presenting as hyperautofluorescent deposit. So to conclude, a large variety of lesions can present as yellow spots in the fundus. Thorough fundus examination, including periphery of the fundus, is mandatory. One must concentrate on the appropriate history and relevant ocular findings. We must suspect the common things first and then investigate and diagnose to confirm the diagnosis, and always refer to a colleague if you are not sure what is you are dealing with. But one thing I would like to say to the general ophthalmologist is always take a photograph at the baseline, as lesions tend to change, and a baseline photograph may help in the diagnosis later on. Thank you. Thank you.